Good morning. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. And we are here today with Dr. Kristen Pettit. And Kristen has spoken at many of our events in the past and on our webinars. She is an clinical associate director or professor at the University of Michigan, not too far from where we are today. And she does a beautiful job presenting on the subject of newly diagnosed patients, what they should expect, current treatments. And for anybody that has questions, please send them our way through the chat, and I will make sure I get to those within a few minutes. Thank you. Kristen?
Okay, great. Thanks so much, Anne. Thanks so much for the invitation to be here, and thanks for everybody for tuning in. I'm going to share some slides here. Okay, let's put it in the big view. All right, Anne, can you see my slides okay?
Yes, they're great.
Okay, sounds good. All right, thank you. Okay, great. Well, I'm going to try to keep the slide portion relatively brief here because I think the questions are really the most important thing to spend most of our time on. But I wanted to give just a little bit of a roadmap for MPN management. I hear that there are a lot of new faces that have been attending these last few events. So I wanted to start out with kind of what to expect if you're newly facing a diagnosis or a possible diagnosis of an MPN in terms of the workup, and then as far as early management too. I'll get into at the end a little bit more of some of the advanced management topics as well for folks who may have been dealing with this for a bit longer. So hopefully a little something for everybody. So first of all, MPNs, if you're kind of new to this terminology, myeloproliferative neoplasms, this is a group of closely related bone marrow disorders, initially generally characterized by overproduction of blood cells. So we see here a picture of a bone with the spongy inside, the bone marrow here being the organ that produces all your blood cells for your body. White blood cells that help fight infection, red blood cells that carry oxygen throughout your body, and then the platelet cells that help the blood to clot. So in MPN disorders, typically the bone marrow is overstimulated and overproducing one or all of these types of blood cells. And along with that, also the bone marrow additionally produces these other proteins called pro-inflammatory cytokines, which we'll talk about a little bit more. The result of this overproduction of blood cells and overproduction of inflammatory cytokines can be a number of different things. The four things we really think about and watch for are, number one, something we call constitutional symptoms, which include symptoms like fatigue or tiredness. That's the number one most common thing that we hear in the clinic. Weight loss, fevers, chills, night sweats, those kinds of things. The second thing we watch for are thrombosis or blood clots. Blood clots can occur in veins, which is like a deep vein thrombosis, a DVT, where one leg can become big and swollen and painful, usually below the knee, or PEs, pulmonary embolism, which is when one of those blood clots travels to the lungs. It can feel like shortness of breath or chest pain. You can also have blood clots in arteries, which are things that we've all heard about before, like heart attacks or strokes. The third thing that we watch for is a risk of progression to myelofibrosis, where scar tissue or fibrosis starts to build up in the bone marrow, and the blood counts typically at that point start to drop lower rather than being too high. And then the fourth thing that we watch for, which is fortunately more rare, is risk of transformation to acute myeloid leukemia, AML, which is a related bone marrow disorder that behaves a bit more aggressively for most folks. And there are possible treatment options, but we watch for that starting to develop and try to pick that up very early if it's there. So looking at the different types of MPNs, so the most common types that we are going to be talking about today and focusing on ET, essential thrombocytosis, PV, polycythemia vera, and MF, myelofibrosis. There are a few other rare MPN disorders that are out there as well. Chronic neutrophilic leukemia, chronic eosinophilic leukemia, and another disorder called MPN unclassifiable that doesn't really fit into any of these buckets perfectly. So what to expect when an MPN is first suspected? First thing will be blood work. probably a lot of blood work. And I'll go over what a lot of these blood tests are that we send off and why we do them and how to interpret the results. Expect a lot of questions about your medical history. For example, prior blood clots, bleeding history. If you're a female, pregnancy history is often important here too, so expect some prying medical questions. A lot of questions about your symptoms and the impact that these symptoms are having on your overall quality of life and your day-to-day functionality. Expect a physical examination with really a focus on your spleen right up here on the right side of your abdomen, right underneath your right rib cage. Expect in most cases to be having at least one bone marrow biopsy at some point too, and I'll go over this a little bit. And then genetic testing, which can happen either from the bone marrow if a biopsy is being done, or it can happen from blood tests. So a little bit more about these blood tests. I wanted to show you some blood smears because this is one of the reasons I went into hematology is I think blood smears are so fun to look at under the microscope and to be able to follow along over time and actually see the impact of our treatment and see things looking better in many cases. So this is what normal blood looks like under the microscope. These are red blood cells. I hope you can see my cursor. The majority of the cells that you're seeing here, the round red circles, are the red blood cells. The tiny little dots, darker dots that are mixed in here are the platelet cells. And then the largest of the cells with these kind of funny globular looking things in here, these are the white blood cells with the multiple lobes of the nucleus that you're seeing there. This would be a normal, healthy blood smear. Oops, oh, I even have arrows. There we go. So looking at a blood smear from someone with ET, so some of these smears are actually from some of my patients who have given permission to show them, and some are from an image bank that's online. This ET blood smear, you can see here a lot more of these platelets, a lot more of the little dark dots there. This is a blood smear from somebody with polycythemia vera. You can see how many red blood cells are here as compared to the normal blood and how little empty space. And then here's a patient with myelofibrosis. You can see that the red blood cells are much more spaced out, much fewer red blood cells, very few platelets in this particular patient too, and fewer white blood cells. We see instead of being too high, the blood counts are now too low in this situation. So the CBC, or complete blood count, this is generally going to be done periodically over time in your case. It could be anywhere from every week or even sometimes a couple times a week, depending on the situation, out to maybe once or twice a year if everything is very stable. The blood CBC is really kind of our gold standard to follow what's going on for most folks with MPNs. So it gives us initially a good clue about diagnosis. It can help us tell prognosis, depending on how high or low some of the blood counts are. It can tell us if we're meeting our treatment goals and how the response to treatment is going. And then it can help us look out for any signs that the disease is progressing or acting up down the road. So kind of how you'll see this look over various different disease states. Red blood cell number, some of the normal ranges are shown here. I won't walk you through all of these. But in ET, generally, the red blood cells are pretty normal. PV, they're increased. Myelofibrosis, they could be normal or decreased. White blood cells could be kind of all over the board in depending on which of these disorders you're dealing with. Platelet count in ET is almost always elevated. In PV, it's also almost always elevated. And in myelofibrosis, it's often low or sometimes normal. The hemoglobin and hematocrit kind of go along with the red blood cell count and follow the same trend. As far as the red blood cell measurement, so we're looking at a few different things here. We're looking at hemoglobin, which is the actual molecule shown over here on the right, the actual oxygen carrying molecule. That's one way that we measure red blood cells. The hematocrit, or the actual kind of proportion of the blood component that is made up of the red blood cells, that's another way we measure that. The red blood cell number itself is a third way. These three things tend to go together, the hemoglobin, hematocrit, and red blood cell number. When one's elevated, they all tend to be elevated. And then the last one is the mean cell volume, or MCV. I get a lot of questions about the MCV in clinic because it's often quite off in folks with MPNs for various different reasons. So the MCV, or mean cell volume, is basically how large the red blood cells are. When somebody, there are a couple of reasons that the MCV can be low in these disorders. For example, if someone is iron deficient, like someone with polycythemia vera who's been getting therapeutic phlebotomies, we'll talk about all those things, typically causes iron deficiency. That's the goal. And then the MCV actually drops lower. There's less hemoglobin in each of these red blood cells, and they kind of shrink down and are smaller. In people who are on certain medications like hydroxyurea or hydrea, this MCV tends to be larger. So the red blood cells tend to be a bit bigger and more plump. That's how hydrea works. That's what we expect. So in that case, we can use the MCV as kind of a little bit of a clue of whether somebody's taking their medication or not if they're on hydrea. So that's another thing we watch for. The white blood cell differential is another question that I get a lot, something that we pay a lot of attention to in the clinic. This is how it looks here on our readout in our lab, and every lab will be kind of similar. So it will list out all of these different cell types here. These are all different types of white blood cells: neutrophils, monocytes, eosinophils, lymphocytes, basophils. These are all cells that we typically see in the blood. And in folks with MPNs, we can often see this percentage, kind of the proportion of each one of these cells in the total white blood cell count. We can often see this a little bit off or skewed, oftentimes with neutrophils being a bit too high, sometimes with these eosinophils or basophils being a bit too high as well. So the percentage is the first thing that we look at, and then the absolute number is the second thing. So when you're looking at these percentages, this particular person had a white blood cell count of 6.5, which was normal, with 52% neutrophils. So then when we look down to the absolute, 52% of 6.5 is 3.4 there. So that's the absolute neutrophil count. So that's kind of how all these numbers play out. So sometimes we can see kind of a skewing in the percentage of certain types of blood cells, but then the absolute number is sometimes completely normal. So it's important to kind of look at both of these things. One thing we're watching for here in the differential is any more immature blood cells that are not supposed to be popping out into the blood. So we can see here, this is kind of the life cycle or the genealogy of white blood cells. So it all starts with a blood stem cell that then takes a turn into becoming either a myeloid stem cell or a lymphoid stem cell. The next step down each of those paths is a blast cell, either myeloblast or lymphoblast. Those are very young white blood cells. Myeloblasts or lymphoblasts, we all have a few of them in our bone marrow. There's a normal stage of blood cell development, but they're supposed to only stay in this blast stage for a very short amount of time and then mature out into these normal, healthy, more mature and functional white blood cells. And they're not supposed to leave the bone marrow and be seen in the blood. Commonly in MPNs, though, we see that these MPNs typically start with a disorder of the myeloid stem cells. So we typically see the myeloblasts being produced at too high of a number oftentimes, and sometimes even being mobilized to leave the bone marrow and go into the blood a little bit sooner. So we can sometimes see these pop out into the blood. Oftentimes we'll see them at kind of 1 to 2% of the overall blood cells, which is often nothing to be too concerned about. But if that number does start to go up, that's something that we watch for and something that can make us start thinking that something more aggressive like a leukemia in the bone marrow could be starting to happen. But 1 or 2% here or there are pretty common to see. Other important labs, basic metabolic panel, you've probably seen tests electrolytes and kidney function. The comprehensive metabolic panel looks at all of the above plus liver function. The LDH, or lactate dehydrogenase, is an enzyme that lives in blood cells. When the bone marrow is overactive or proliferative, like in folks with these MPN disorders, that LDH number tends to go up. It's something that we follow more as far as a trend than the absolute number. It'll kind of go up and down a bit over time. I will point out that LDH is not the same as LDL. LDL is cholesterol. LDH is an enzyme. Totally different things, same first two letters. So I get that question a lot. Uric acid is similar to LDH. It's produced in white blood cells primarily. If the bone marrow is proliferative or making too many cells, that uric acid level can go up. Uric acid, if it builds up in too high of an amount, can cause a couple different problems in the body. It can cause gout, which is not fun in the joints. It can also cause kidney disorders too. So there are medications we can use to try to keep that down. And keep people well hydrated can help too. I'm sorry, can you all hear me okay? Hold on a second. Got a message that you can't hear me though. Let me try this. Is that better? I hope that's better.
Yeah, Kristen, I think it was just, you were fading in and out a bit.
Okay.
When you look at your computer on the side, it seems to be better, but you're doing fine. We can hear you.
Okay, sounds good. I just switched the microphone over, so hopefully that'll help. Okay, sounds good. So next, bone marrow biopsy. So bone marrow biopsies are necessary for most situations for people with new diagnosis of an MPN. Potentially not for 100% of people, but it's a little bit controversial. So I think bone marrow biopsies are very important because it can confirm the diagnosis and rule out some other disorders that can mimic MPNs. Can also help us determine prognosis too. We can get some other tests, some other genetic markers from the bone marrow that are hard to get from the blood. It can help us down the road check for response to treatment for certain disorders, and it can help us look for progression if we see any signs of that in the blood. So bone marrow biopsies are relatively straightforward. They're done a little bit differently in different places. Here at University of Michigan, I'll just put in a little plug for our team. We turn on music, you get a back massage. It's kind of a whole experience. Nobody comes in asking for a second one necessarily, but they shouldn't be really painful. They can be a little uncomfortable or pressure-like, but hopefully most folks only need one over the course of their lives. So really what we're doing is with the bone marrow biopsy, you can see here this person's laying on their stomach. You can see the back of their hip bone here, kind of in a crest shape right there on the right back of the hip bone. We take just a very thin needle and numb things up very well first, and then put it through the actual hard bone and into the spongy bone marrow here to take a sample in order to look at in the lab and be able to run more tests from. I'm about to show a real sample of bone marrow here, so if you're squeamish at all and want to look away for a second, I'll tell you when to look back, but here's a real sample of bone marrow. This is what it looks like when we get the core sample out, the solid sample of bone marrow here. So it's pretty small. This one is actually a pretty big sample. This is a pretty healthy sample size-wise. Usually we're taking out about 1 to 2 centimeters here, so we can look at the actual architecture of the bone marrow in addition to the individual cells. So here's how that looks under the microscope. This is normal bone marrow. We see these kind of fat cells here is the white empty spaces, and then all the filled in spaces is the blood producing cells from the bone marrow, and this is a healthy looking bone marrow. You can see in ET or PV, we see too many cells. This is called a hypercellular marrow. We see the cells kind of starting to fill up the bone marrow space and less of the fat or empty space here. In myelofibrosis, we can see less blood forming units here, and instead the bone marrow starting to be occupied by this black or gray kind of stringy looking stuff, which is fibrosis. This is actual scar tissue that should not be there in normal healthy bone marrow. Okay, interpreting your bone marrow biopsy report. This is something that I'd always recommend talking to your doctor about because there are a lot of words here, there's a lot of descriptions here, and it's easy to get caught up in the jargon. So I have these slides here. I'll make sure Ann has the slides available to send out to if anyone's interested, but I'm gonna kind of skip through this a little bit if that's all right too, so I can get to some other things. So gene mutations, this is another thing that your doctors will be testing for in your cases. Gene mutations are what drive MPNs. So we know that genetic mutations in a gene called JAK2, J-A-K-2, drives the majority of cases of MPNs. So JAK2 is kind of like a thermostat for the bone marrow. When your in normal healthy situations, the JAK2 gene is supposed to tell your bone marrow when you need more blood cells for your body and tell the bone marrow to rev up. And when you have enough blood cells, that JAK2 gene is supposed to tell your bone marrow that, so your bone marrow can cool down. What happens in MPNs, though, is that an activating mutation occurs in that JAK2 gene that causes that thermostat to get stuck in the on position. So the bone marrow is just constantly getting this signal to churn out more and more cells. So we see that JAK2 mutation in almost everyone with a diagnosis of PV. That's really, if we don't find a JAK2 mutation and we think somebody has PV, we should be rethinking the diagnosis because it's almost everybody that has that mutation.
In ET, about half of patients will have that JAK2 mutation, and a large percentage will have a mutation in a gene called CALR, or a smaller percentage in a gene called MPL, MPL. I'll show how all of this fits together in the next slide. And similarly, in myelofibrosis, we see most people have mutations in JAK2, but CALR or MPL mutations can happen as well. And there's always a small subset here of folks who don't have any of those 3 mutations, and we call that triple negative. So here is how this works inside a cell. This is a cell on the left here with a JAK2 mutation. Everything underneath this gray kind of crescent is the inside of the cell. The JAK2 protein sits right there on the inside of the cell. When it develops a mutation, it activates this whole pathway that happens inside the cell that causes the bone marrow to produce, some abnormal genes to be overexpressed or produced, and the bone marrow to become proliferative. On the right here is how the CALR and MPL mutations fit into all of this. We see the JAK2 protein on the inside of the cell. On the outside of the cell, we see this mutant CALR, which is a protein that can circulate in the plasma and then bind to this receptor on the surface that's called MPL, and then activate JAK2 inside the cell. So all of this is part of the same pathway inside the cell, but the way we get to that activation can be a little bit different depending on which of those 3 mutations are there. This is what's called a karyotype. This is the portion of the testing that we can't get easily from the blood, and one of the reasons that we often do a bone marrow biopsy to start out with, which is to look at these individual chromosomes. So on each one of these individual chromosomes, this is where all those genes sit. Like this JAK2 gene is here on the 9th chromosome. We obviously can't see that gene with the naked eye, which is why we do more detailed testing, but we can see actually the chromosomes themselves under a microscope, and they look just like this. And our cytogeneticists down in the lab can look at this visually and with computer programming and figure out if there are any kind of chunks of chromosomes that are missing or stuck together or added another copy, those kinds of things, which can be important for the diagnosis and prognosis too. So getting into some treatment considerations, really treatment for everybody with an MPN should be very individualized, very personalized to your particular situation. The things that we take into account when we're making these decisions in the clinic include the symptoms and how bothersome they are to your particular life. The second is the risk of thrombosis. Not everybody's risk of a blood clot is the same. So we know risk factors can include older age. The age of 60 is the cutoff that we've used in the past, although I get this question a lot, and I totally understand not all 60-year-olds are the same as far as other cardiovascular risk factors and physical fitness and those kinds of things. But we do know age just longitudinally is a risk factor for blood clots. Having a prior blood clot puts you at higher risk for a future blood clot. That's another thing. Having cardiovascular risk factors, heart disease, prior heart attack or stroke, smoking, that's another thing. Having the JAK2 mutation as opposed to the other mutations can also go along with blood clot risk. We also take into account other medical issues in your history, as well as personal preference about how aggressive or non-aggressive you'd like to be with your care and what type of treatment plan suits you best. For ET treatment basics, aspirin is really a cornerstone for treatment for most people to help prevent blood clots. Just a low dose aspirin, 81 milligrams a day, the baby aspirin, is very helpful for most folks. You may have heard out in the news over the past year some big news stories about aspirin not being, or the risks of aspirin being higher than the benefits for a lot of people out there. That does not apply for folks with MPNs. So if you've seen those news stories and unless your doctor has told you, don't go ahead and stop your aspirin. Talk to your doctor about it first, because for most people with MPNs, we're still continuing aspirin. Lifestyle modifications are helpful: exercise, nutrition, keeping those cardiovascular risk factors under control, those kinds of things. And then medications. So medications for ET we call cytoreduction. These are medications that can help slow down the production of blood cells, as well as slow down productions of some of those inflammatory cytokine proteins that I mentioned as well. So all of that together can help keep you better protected from blood clots and help treat some of the symptoms related to the disease. I'll talk about the options, but the first line options that we typically consider for folks with ET are either hydroxyurea or hydrea, or pegylated interferon or Pegasus. There are some other treatment options as well. Anagrelide is one that is out there that can lower platelets, so we can talk about a little bit if folks have questions about it. We don't use it as frequently anymore as we used to. And there are a lot of clinical trials or investigational medications that I'll mention too. For polycythemia vera, you'll see that this slide looks very similar. Aspirin generally is recommended for all patients unless there's a reason not to. Therapeutic phlebotomy, which is basically like blood donation, except that we don't donate the blood, we just remove the blood cells. Generally keep the hematocrit goal less than 45% for most people, but again, that can be a little individualized to different situations. The same lifestyle considerations, and then cytoreduction medications as well. Here for PV, our options are hydroxyurea, one of the interferons, including either pegylated interferon or Rho-peg interferon that I'll mention in a couple slides. And then we can consider JAK inhibitors like ruxolitinib or clinical trials, investigational agents. As far as our options for most folks with either ET or PV, we've got the hydroxyurea that I mentioned versus the interferons. Hydroxyurea is nice in that it's a pill. You can take it once or twice a day, depending on the situation and how high your blood counts are. It really serves as kind of a dampening blanket on the bone marrow. It'll cool down blood cell production across the board, all three of the blood cells, white cells, red cells, and platelets, as well as some of the inflammatory proteins. It can have some side effects, although it's generally really well tolerated, especially at the low doses that we use for most people with ET or PV. Can have some GI issues like nausea or bloating or diarrhea. Can see some hair or skin or nail changes, generally kind of dryness or sometimes thinning of the hair a little bit, but not generally hair loss. And then occasionally we can see mouth sores. The interferons are a little bit different. They're more like a biologic agent. Instead of just kind of a dampening blanket on the bone marrow, they kind of skew the bone marrow back in a bit more of a healthy direction. There's two main forms that we use in people these days. One is pegylated interferon or Pegasus, and the other newer version is Rho-peg interferon or Best-Remi. These are two slightly different interferon formulations. The Pegasus is once weekly. The Best-Remi is every 2 weeks. These are self-injectable treatments. So for folks with major phobias of needles or those kinds of things, this may not be the best treatment for some people, but you don't need to find a vein or anything like that. It's just an injection under the skin, similar to an insulin injection. So most folks can become comfortable with this faster than you might expect. Possible side effects with the interferons are a little different than hydroxyurea. You can see flu-like symptoms like fever, fatigue, achiness, headaches, those kinds of things. Typically gets better over time, but that can happen at first. Occasionally some nausea or vomiting, and occasionally some like worsening of depression or anxiety too, which is something we really have to ask people about and make sure we're watching for, because that's a little bit of an unusual thing that you don't usually think about with medications. As far as which one to choose for which individual person, there's a lot of decisions, a lot of factors that go into this decision. These two things, hydroxyurea and PEG interferon, or hydroxyurea and Rho-peg interferon, have been compared head-to-head in a number of different clinical trials. And I'll spare all the details in the interest of time and wanting to get to questions, but essentially these two things, hydrea versus interferons, are essentially equivalent as far as their ability to control blood counts and their ability to prevent blood clots. What we don't know so much is down the road, we do know that hydroxyurea is very unlikely to be able to prevent the disease from progressing down the road. What we don't know is so much about the interferons. There's some suggestion that we might be able to see some improved outcomes down the road as far as prevention of disease progression and things like that for folks on interferons, but that's really not well proven yet. So it's one thing we think about and talk about in the clinic, but it's kind of a to be determined sort of thing. So how we choose, we take into account personal preferences, other medications and possible side effects. Age is one thing that goes into the equation too, and pregnancy plans. The interferons, especially Pegasus or the earlier interferons, are likely safe in pregnancy, whereas hydroxyurea is not. Cost is another real consideration, practical, real world consideration. Hydroxyurea is cheap, whereas the interferons are not. and are often covered by insurance, but not always. And then in the future, maybe we'll have some other biologic or genetic features that we can use to kind of choose which treatment is best for which patient. I'll skip over JAK inhibitors for ET and PV because we're going to talk about them for myelofibrosis here. So getting into myelofibrosis, this is exciting. We now have 3 approved JAK inhibitors for myelofibrosis, and we have a 4th that is likely coming. So those that are here, ruxolitinib, fedratinib, and pacritinib are all currently FDA approved. Momelotinib is the 4th that we expect is likely going to be FDA approved around January of this year, but we're still waiting to hear on specifics about that. So ruxolitinib or Jakafi is most common first choice. Fedratinib or Inrebic is often a common second choice, although it could be a first choice for some situations. Pacritinib, the new kid on the block, is what we typically use for those with platelet count less than 50, so very low platelets because it's easier on the blood counts. And then momelotinib is being developed specifically for patients with myelofibrosis and anemia to try to improve the red blood cell count. So I'll go through these just very, very quickly. Ruxolitinib or Jakafi has been around since 2011. It was approved and studied for many years before then. So we have good long safety track record and data on Jakafi. It's helpful in reducing the spleen size and symptoms and may help improve quality of life and length of life for some folks too. I'm about to show another kind of graphic picture. So if you're not interested in this, you might want to look away for a second. I'm about to show you some pictures of spleens. So first, this is what happens in mice who are given myelofibrosis in the lab and then treated with Jakafi. So the first over here is the spleens of mice who have myelofibrosis. They're quite large. You can see the ruler over here. And then after treatment of those mice with Jakafi, you can see that the spleens shrink down very nicely, which is the goal of the treatment. This translates in humans as well. So those who received a placebo, we see that the spleen just kind of grew as expected, or at least stayed stable, didn't get any better. And then those treated with ruxolitinib or Jakafi, we see nice spleen volume reductions here. This is percentage of spleen reduction over time. Okay, and you can look back if you looked away. So downsides of ruxolitinib, overall, it's really well tolerated. We can see some dizziness or headaches, but not in the majority of folks. What we can see more commonly is lowering of the blood counts, worsening of anemia, thrombocytopenia, the platelet lowering, as well as neutropenia, white blood cell count lowering in some. Also expensive, and we know it doesn't prevent transformation to acute myeloid leukemia, unfortunately. Some of the newer JAK inhibitors, so fedratinib or Inrebic, was approved in 2019. So we've had it for a number of years now. It can help reduce the spleen and the symptoms, sometimes even if ruxolitinib hasn't, even though its mechanism of action is quite similar. It probably has enough differences compared to ruxolitinib that even if ruxolitinib stops working, fedratinib can be a good second line choice. It may have some impact on bone marrow fibrosis as well. I'm showing you down here some pictures from under the microscope of a patient with myelofibrosis. The bottom row here is that reticulin fibrosis stain, the actual scar tissue, and the gray lines that are shown here. You can see over time in this particular patient, those gray lines really went away, and the bone marrow is looking much healthier. On the top here, you can see kind of filling in and more normalization of the bone marrow appearance. Side effects with fedratinib, mostly GI issues, nausea, diarrhea, even to the point of possible malabsorption, so we have to watch some vitamin levels. When that happens, it's usually pretty early on and gets better over time, so it shouldn't necessarily scare us away from using the drug. We've just got to be prepared for it. The newer drug, pacritinib or Vonjo, this is a more selective JAK2 inhibitor. The others all also hit this JAK1 target, which lowers blood counts. Pacritinib spares that JAK1, so it's a little bit lighter on the blood counts overall. It was just approved in February this year, specifically for patients with platelets less than 50. And notable side effects, GI issues can happen here too, similar to the fedratinib, in that it tends to be kind of early on when people first start the medication and get better over time. We can also see some EKG changes with pacritinib that we see with a lot of other medications as well. So we just have to keep an eye on EKGs every so often. So as far as clinical trials for MPNs, research is moving really fast. There are a lot of investigational options available, a lot of things that you may be interested in considering either now or down the road. If anyone hasn't come across this website already, this is a nice way to look at them. Clinicaltrials.gov is the website, lists all of the clinical trials out there that are open and available. When I just checked this morning for MPNs, just to get numbers of where we're at right now, you see that for ET, there are currently 49 studies that are open and enrolling around the country. For PV, there are 46 studies, and for myelofibrosis, there are 97 studies. So I sometimes joke that it feels like there are more clinical trials than patients with these disorders, and that's a great situation to be in, that all of this attention is going into these disorders and all of these new treatments are being tested and hopefully moving through to be able to be more widely applicable for everyone with these disorders. I promise I'm not going to take you through this crazy picture that I had made a while ago, but I just wanted to use this to illustrate. This is the inside of a cell here, and this is the inside of a nucleus, and then the upper part is the outside of the cell, either the blood or the bone marrow environment. Everything that's shown here in this picture are steps in the normal life cycle of a cell that are dysregulated or abnormal in MPNs. And everywhere where there's a white box here, these are all steps that are being targeted therapeutically, where new treatments are being developed to try to target these abnormalities. So this is just a small snippet of what is going on out there in terms of research, but I think it's really exciting, and there's a lot to be really hopeful about for the future with MPNs. Oh, and then I just had to include this because if you didn't know, University of Michigan is still undefeated in their football season, so it's very exciting.
Go blue, kinda.
You don't have to agree with me on that one.
Yeah, no, it depends on what's happening, who they're playing. Kristen, that was beautifully done. Thank you so much. That was so informative. We have a ton of questions for you as usual.
Great.
And I want to start with the first two. I want to start with a lot of our patients have random CBCs, complete blood counts, like maybe annually. And in this case, the patient asks, so, she had her blood tests and it showed ET. I mean, she was diagnosed with ET. She said no symptoms whatsoever. There's two schools of thought out there after all these years of being in this space. I hear it now quite often. And that is, do you start treatment right away, even though she has no symptoms? Or do you wait until that wait and see comment that is made quite often?
For ET?
For ET.
Yeah, I think it's tough, and it's really got to be personalized. We use those factors that I mentioned to try to predict what the chances are of things happening down the road and try to use that as our guide as far as when it's time to start treatment. So there are good scoring systems or prognostic systems to predict the risk of blood clots. And when people get, over a certain score on those systems, on those scores, then typically starting a medication is worthwhile to try to bring that count down. But a lot of other things rather than just those prognostic scores go into that decision. So somebody's overall lifestyle, their physical fitness level, their other medical problems, those kinds of things. So I don't think there's a good one-size-fits-all answer to that question.
Okay. And okay, the other thing that we hear pretty consistently from our patients, and I can't tell you if it's ET or PV or MF, honestly, but this question is from a PV patient asking about bone pain. And I can't tell you how many patients we've talked to who have said the physicians dismiss this as not an MPN symptom, but as something else. You may have done something else is happening. Could you speak to the bone pain issue?
Yeah, I get that question a lot too, and it is a tricky one because, a lot of things can cause bone pain, and not all bone pain is the same. Certainly, arthritis is so common, all of these kinds of things can be contributing to, but MPNs can absolutely cause bone pain. You think about the bone marrow as opposed to other organs, it's really encased by this solid bone, so there's only so many places it can go. If it's proliferative, if it's overactive, and if there are these inflammatory cytokines being produced in there, it can't swell like other organs can. It's really enclosed there in the hard bone, and that creates pressure, and that can be uncomfortable. And what's really not well understood is why that pain tends to kind of go up and down for people. If there are some people have certain triggers that are clear, but I think for most people it just tends to go up and down without clear triggers from what I hear from my patients. And it is tricky. I think it is a more common symptom than is realized. There are a number of different things that can be done about that. I do think that anything that lowers some of those cytokines or slows down some of the proliferation can help the bone pain a bit. So the cytoreductive agents, the medications, either the interferons or the hydroxyurea, can help that a bit. I think other lifestyle things that can cool down cytokine production, like exercise. I know yoga has been a thing we've talked about before, can actually lower cytokine production in the body. An anti-inflammatory diet like a Mediterranean diet, all those things can help a little. I'm not saying they're going to take away the symptom entirely, but they could help a little bit. And then some of the medications like the JAK inhibitors, if there are other, if the symptoms are that bad, or if there are reasons to start those, are actually quite good for bone pain. But you've got to take into account kind of pros and cons. So whatever you can do without too many side effects, like these lifestyle sorts of things, are sometimes really helpful for folks.
So you mentioned drugs that have been approved by the FDA and those that are coming down the pipeline, which are quite a few actually. Mm-hmm. But I have a question here about the difference between pegylated interferon and Besremi. Mm-hmm. And we have gotten in the last week, Mallory checks Facebook consistently. You know, we're on a gazillion Facebook sites, and there are thousands of patients there. We are hearing consistently praise for Besremi, and that it's doing so well, and that the patients are doing so well. So can you tell us the difference between those two?
Sure, yeah. So they're very similar. They're both interferon formulations. So interferons are these inflammatory proteins that are in all of our bodies to start out with, and are kind of dysregulated. They're there in abnormal percentages in folks with MPNs. So giving this particular protein, the interferon alpha, can help kind of correct that imbalance a bit and help skew the bone marrow a bit back towards normal. Interferons have been around for a really long time. There are older versions that were given at very high doses for different disorders, and sometimes given 3 times a week back in the old days. These days, though, with Pegasus, or pegylated interferon, that's the once-weekly injectable version. It's a little bit smoother than the every 3 weeks, where there was a lot of kind of up and down with symptoms. And then the Besremi or Ropeg interferon, that's every 2 weeks, is even a little bit, I think, smoother still as far as levels in the body go. What I can say is, you know, they're very similar. They're very slightly different interferons. And the length of action is longer, of course, with the Ropeg interferon, the newer version, Besremi. But I can't tell you which is better. They've never been compared head to head. I doubt that they will be ever compared head to head in a clinical trial. So I can't tell you which one is better for symptoms or for blood clot prevention or anything. I think they're both quite good. The Besremi is approved in the US so far for polycythemia vera, but not for ET. There are studies going on in ET right now, so hopefully it'll get that indication for ET eventually. So right now, as far as which one we go with, to be very frank with you, oftentimes insurance companies make that decision and not us. What the insurance company will cover is usually what guides us in one direction or the other. I think they're both excellent options, though.
Yeah, and I think the fact that Besremi was approved by the FDA for PV and PEG isn't. Is the big difference in terms of payers and what needs to happen in that respect. Okay, so I have a lot of questions for you. Do you see pseudo high potassium readings in your ET patients who are taking hydroxyurea?
All the time, yes. And not just with hydroxyurea. I don't think hydroxyurea has much to do with it, actually. If anything, it might actually make it a little bit better. But yeah, so high potassium levels, I get that question a lot. I haven't seen somebody ask this in these forums before. I love that question. Yeah, it's very common to see high potassium levels. Potassium is there in blood cells in general. And when your body is making too many blood cells, whether it's white blood cells, red blood cells, or platelet cells, when they draw that tube of blood and they send that tube over to the lab, you can see it sometimes takes an hour, 2 hours to get those results back. That tube is sometimes waiting in limbo a little bit. While it's waiting in limbo, some of those cells are kind of breaking up and releasing some of the substances in them, and potassium is one of them. So we can very commonly in people with MPNs and too many blood cells see that potassium level rise above the kind of normal range. Typically not super high. If we're seeing potassiums in the 6s, then I usually do a little bit more workup and see. But if we're seeing it in the 5s, usually normal potassium is up to, depending on the lab, 4.5 to 5. If we're seeing it in the 5s, I usually assume that it's this pseudo hyperkalemia thing, meaning that it's just the blood cells breaking up in the tube on the way to the lab. And that's very common. That's of no clinical importance to your body, but it's something that we, keep an eye on. And it's not something that you have to adjust your diet or look into kidney function issues or those kind of things, as long as it's mild. If we're not sure, there are some ways we can draw the blood a little differently and we can figure that out, but it's a little bit of an ordeal. So if it's very mild and the blood counts are very high, we usually just keep an eye on it.
Okay. Can you explain, this has been going on for years, ever since I've been in this space for almost 20 years. Can you explain the role that allele burden plays in effectiveness of treatment?
Yeah, hopefully we'll have an answer to that question a bit more over the coming years. It's still very undetermined. So to explain that a little bit more. So the allele fraction or frequency, which you'll see also listed as VAF, variant allele frequency, has to do with how many of those cells have the abnormal gene mutation. So for example, if you can see on your JAK2 mutation reports a variant allele frequency of 5 or of 55 or all over the board. And what that means as far as prognosis or as far as diagnosis even, or as far as long-term treatment impact is really still unclear. We know in a lot of the data that we have is kind of taken from CML, chronic myeloid leukemia, which is a totally different MPN with totally different treatments that we're not talking about today. But in CML, we have such excellent drugs that medications that really that treat the disease so deeply that we can see there with that abnormal gene, we can see those variant allele frequencies or the abnormal gene transcript really go down below detectable ranges for many people and even 0 for many people. And for these disorders, for these MPNs that we're talking about, ET, PV, and myelofibrosis, we unfortunately currently don't have treatments that are that impactful as far as reliably being able to bring down those numbers. So with the treatments that we do have available right now, we currently still don't really know what our goals should be, and as far as bringing those numbers down, and if, let's say, a 10% change is meaningful, if a 20% change is meaningful, we don't have any of those answers yet. So with pretty much every clinical trial that I had pulled up before, that high number of clinical trials that are being done, almost all of them are looking at that question to see how that variant allele frequency changes over time, and if that kind of correlates with other measures of disease response or length of response or anything like that. So that's a long-winded explanation to say we still don't have a great explanation.
Okay. Oh my gosh, these questions are excellent. So how likely is a person to progress to MF if there's a history of MF in the family?
If there's a history of MF in the family, so do you mean as far how often in somebody who's healthy, how often developing MF?
I'm not quite sure.
Okay, well I can
say this person has ET.
Oh, okay. And they have MF in the family? Okay. Yes. That's interesting. Yeah, I think, back even maybe 10, 15 years ago, if you were to ask an MPN doctor if these disorders were inherited, the answer would generally be no. But these days we've realized that that's really not the case, that there are probably inherited susceptibility, some families that have susceptibility to these disorders. these mutations themselves, like the JAK2, CALR, and MPL mutations, are typically not directly inherited. So if you look at like breast cancer, folks with those BRCA mutations that you may have heard about, those are directly inherited from a parent to a kid. These mutations in MPNs are not directly inherited, but there may be some other kind of underlying predisposition that in some families that there may be a higher risk than in other families of developing these things over time. And that's really still being worked out. We still don't have a great understanding of what those factors are. That's a really good question. If you have ET and a family member had an MPN that progressed to myelofibrosis, if the risk is any different for you, and I don't know that it is. At least I don't know of any data that would say it was any different than anybody else with ET. So I think the risk is still very low, but of course, obviously, still worth looking into. All the other genetic factors that can be playing a role and keeping a close eye on it down the road.
I know Angela Fleischman is doing a familial study. Dr. Wadley did a familial study, but Angela's is ongoing. So perhaps we could send this person to her. And
that's a great idea. That's a great idea. Yeah.
And so this is a good question. Other than a CAT scan and possibly a physical exam, how can you tell if your spleen is shrinking from taking Jakafi?
Good question.
About how many years or months does it take to shrink?
Yeah, so it depends on the person as far as how we tell if the spleen is shrinking. For the majority of people, we can just feel it with our hands and a physical exam. So for the majority of people, you don't need to be exposed to extra radiation with a CAT scan or to other just procedures with an ultrasound, those kinds of things. Any of those things are great at measuring the spleen, but we're pretty good at doing it just with our hands in the clinic too. So that's the way I do it. If I can reliably feel the spleen, which is probably 90% of people that I can. For some people, there are other either anatomic reasons or they're tender in that area, or they carry their weight in their abdomen. Any of those kind of reasons, it can be sometimes hard to feel, in which case I usually do an ultrasound more often than a CAT scan that has radiation and dye and all of those kinds of things. The ultrasound's a bit easier and less involved. So that's how I follow it, is usually just with physical examination. And as far as how long it takes to shrink down with the JAK inhibitors, it's variable. Sometimes I've had people say that even with the first couple of doses that they felt a difference. If you don't feel that, though, I wouldn't get concerned. We really say we have to give it at least 4 to 6 months to really be able to tell how well it's working, or if it's working. We do have some people where it takes that long to really start kicking in, but sometimes it's faster, so it's a wide range. I wouldn't give it years and years, though. If you're not feeling an improvement after somewhere in the 4-month-ish range, then I usually move on to something else.
Is hydroxyurea kind of the go-to for young ET patients? And, there's a growing number of younger MPN patients. And, we saw this a long time ago and started our pediatric and young adult MPN program. And, typically we hear that it's ET and ET diagnosis. On occasion, in the males, we hear PV. But can you kind of speak to, is that when in your younger patients, do you find that you tend to prescribe hydroxyurea, or are you starting to look at, I know Dr. Silver goes to interferon, and some patients young patients do very well. We have a few that we know that are using interferons. Your thoughts?
Yeah, I think the field overall in young patients is moving more and more towards interferons for ET and PV, and oftentimes in older patients as well, I would say. It still has to be personalized. It still has to be a personal decision based on kind of lifestyle, other medical issues, personal preference, all of those kinds of things, because neither answer is right or wrong. But I think especially in young folks, there's some reasons to consider interferons. One is potential for pregnancy in either males or females. That's something that should be considered. And pregnancy is, we know, not generally safe on hydroxyurea, whereas it generally is with Pegasus, at least. Befremi, we don't have that data so far, but with some interferons, that's one reason. Potential for pregnancy is one. Another is overall tolerability. I do think that younger folks tend to tolerate the interferons a bit better. that's a really blanket statement and kind of an unfair statement, and I don't want that to be taken too broadly, because there are plenty of folks in their 70s, 80s. I even have a patient in their 90s on interferon who does just fine on it. But that's one thing. And then kind of the potential for long-term benefit is the other thing to keep in mind too. We do have signs with the interferons with Pegasus and Besremi that we can see that variant allele frequency going down over time, and over time meaning years. It takes a long time to see those impacts with those frequencies going down, and maybe some improvements in bone marrow fibrosis or prevention of bone marrow fibrosis that's been suggested from some other groups like Cornell and some of the others that have been doing some of this long-term research. What we don't know yet, though, is if that's going to translate into people living longer or having a decreased risk of leukemia or myelofibrosis progression, those kinds of things. We don't know that for sure yet. So that research is still going on. It takes a long time to show those kinds of benefits. But for that, potential benefit in young folks that might be on these medications or dealing with these disorders for decades and decades and decades, I think that's another reason to consider interferons.
So, when I first came into this field, excuse me, the JAK2 gene mutation had just been discovered, although it could have been discovered a few years prior to that, but it was gaining a lot of interest. And now, of course, there are many, many mutations that are associated with MPNs. And so this patient asks, they are diagnosed with primary MF and on Jakafi for a few years. They have the CALR mutation and the AXL, I always say AXL, but it's ASXLI mutation. Do these mutations change the future for that patient in terms of progression and so on?
It's a really good question, and it's a little bit controversial. So the first thing I'll say is whether or not to even test for those additional mutations. So what we're talking about is typically in the past, and oftentimes still many places, what's done is when an MPN is suspected, a physician will order single gene mutation testing for the JAK2 gene or the CALR or the MPL or all three of those. And usually that's been it. These days, though, it's kind of new in our national guidelines and to many of our practices that we order a bigger genetic sequencing panel called a next generation sequencing test, or NGS test. The NGS test gives us a little bit more information about additional mutations that can be there on top of the JAK2 or the CALR mutation. Those additional mutations are sometimes important and sometimes not, and sometimes we don't know. So in folks with ET or PV, it's relatively rare to see those additional mutations. Most people will not have them. They will just have one sole gene abnormality in one of these driver genes. In myelofibrosis, it's much more common, and we can often see 3 to 4 mutations in folks with myelofibrosis. So when we do find those mutations in folks with ET or PV, it's honestly hard these days still to tell exactly what to do with them. The ASXL1 mutation is one that's pretty controversial in those disorders. Some folks have suggested that potentially it is a higher risk mutation, and that people with ET or PV and an ASXL1 mutation might have a little bit of an increased risk of the disease acting up or progressing over time. But that is not necessarily the case across the board, and we haven't really definitively proven that yet either. So it's an open question, and it is despite the fact that I do these next generation sequencing panels for all my patients or recommend them, it is still a question about what we do with the results, and oftentimes we don't know.
Okay, so if a patient is currently on Jakafi and they are about to try a different JAK inhibitor, have you noticed a negative impact from switching?
Yeah, so with Jakafi in particular, but any of the JAK inhibitors, you can get a withdrawal syndrome if we stop them. So this is important, I think, for people on JAK inhibitors to know about. And I always tell my patients, and I hope anybody on JAK inhibitors knows this too, that, if something was to happen to you, if you were hospitalized for any reason, or something was to happen, just stopping that JAK inhibitor cold turkey can be dangerous and can cause a rebound effect of some of these cytokine proteins, which can show up like fevers or like high heart rates or low blood pressure or feeling generally very crummy, all those things can happen. The spleen starting to grow relatively quickly. Any of these kind of rebound phenomenon can happen pretty quickly, actually, when if you hold the Jakafi cold turkey. Typically what we do is taper it down a bit over usually just a week, 2 weeks, usually a pretty quick taper. And we can sometimes use something like a low dose of a steroid like prednisone, like an anti-inflammatory, to kind of bridge that little bit of time to make sure people feel okay. And then if you're going right on to another JAK inhibitor, hopefully then that kind of picks up the slack and keeps those cytokines under control so you don't have those kinds of symptoms. Does that answer the question?
I think that does, actually.
Okay.
So what does it mean if the person's bone marrow biopsy results show that they're negative for JAK2, but a wild type JAK2 was detected?
Yeah, good question. That's
Yeah.
So wild type means normal. So we all have a JAK2 gene in our cells. Like I mentioned, it's supposed to be kind of the thermostat for your bone marrow. So wild type JAK2 means you have a normal JAK2 without that mutation. That's all that means. Wild type, just a convention that's been around forever genetically to say normal.
Okay, good.
Unmutated.
Yeah. So we know several patients who have had a splenectomy. And what effect does a partial or total, I've never heard of a partial splenectomy, so pardon my ignorance, but what does that mean to an MF patient? What happens?
Yeah, so splenectomies, I get that question a lot too. My spleen's getting large, it's uncomfortable, it's part of this disease, why can't we just take it out? I can live without a spleen. Everybody can live without a spleen generally. It does do some functions, but it's one of those organs you can live without. The problem here is that in MPNs, these really are not diseases of the spleen. The spleen's not the problem. It's kind of it's getting roped into the problem. It's kind of an innocent bystander. It can cause other problems in and of itself, but it in and of itself is not the problem. The abnormal cells coming from the bone marrow are the problem, and they just take up home in the spleen and start growing there and cause the spleen to swell and enlarge. So just taking out the spleen can have a couple different effects. Oftentimes when we initially first remove the spleen, because the spleen is producing blood cells for the body in that situation, we often see the blood counts drop lower, and sometimes even kind of bottom out all the way. Then sometimes they do pick back up again, but they do often get worse before they get better. And any impacts of taking the spleen out are generally short-lived, because then those cells usually they just go somewhere else, like the liver, and the liver starts to become enlarged. So we usually don't recommend removing the spleen unless we've tried everything else and it's very uncomfortable and we really need to do it for somebody to be able to live their lives. But what effect that has on a patient with myelofibrosis, those are the reasons we don't do it, but it doesn't mean that any of those things are necessarily going to happen. So I have had patients with myelofibrosis back a while ago. The splenectomies were done more often. And I have patients with myelofibrosis who had splenectomies done a long time ago and then have remained relatively stable since that time. So it is possible, but it's a risky procedure. It has risky impacts as far as your overall health and the blood counts and the possible liver involvement down the road. So typically don't recommend doing it, but it doesn't necessarily mean something like that is going to happen to you.
Okay. And have you seen a high ferritin count in any patients with ET, and what is that indicative of?
Yeah, that's a good question too. So ferritin is tricky. Ferritin is something that we check often. It's tricky because it can mean a lot of different things. So ferritin is basically a storage form of iron, a long-term storage form of iron in the body. So if people have too much iron in the body, the ferritin is often high. But just having a high ferritin does not mean you have too much iron in your body. So ferritin is also what's called an acute phase reactant, which means it's an inflammatory protein. So if somebody, for example, somebody without an MPN was to have a bad infection or like a sepsis kind of event, the ferritin is often through the roof in those kinds of situations. So when we kind of extrapolate that to people with MPNs who have chronic low levels of inflammation in their body, we often see the ferritin be mildly elevated. We can also see it be low, though, in situations like polycythemia vera, where we're doing therapeutic phlebotomies to remove iron, and where the bone marrow is just using up iron to make a lot of blood cells. Oftentimes we see the ferritin actually be low So it's one of those tricky things that can be either high or low in folks with MPNs. And in and of itself, it's not a very easy thing to follow or to know what to do with.
Interesting. So we get this a lot. Two questions. Well, we have several here, but two that I'll ask off the bat. And that is, when does a person know that their symptoms are changing, that it has to do with their MPN?
Mm-hmm.
And when do you know that something has changed in the patient and perhaps start them on a different drug or a different treatment protocol?
Yeah, it can be tricky for sure because there are so many ups and downs. I think that's the norm for folks with MPNs is so many ups and downs over time, and oftentimes people are just having kind of MPN days where they feel more tired or more achy or whatever symptoms kind of flare up for whatever reason on a given day. So it can be tricky. I think what's important is not to make any rush decisions or snap decisions on a day-to-day basis. I think looking at the trends overall over time. I think keeping a symptom diary can be super helpful. I have a lot of patients that do that. I think it helps in a lot of different ways. It helps to track how you're feeling and to pick up signs of the disease progressing or responding to treatment, either way. I think it also helps mentally. I think there's a lot of data about journaling with depression and anxiety and with chronic diseases that can help a lot as far as the mental health aspects of these diseases. So I think that can kind of really be helpful for people with MPNs, keeping a symptom journal. Then from our standpoint in the clinic, when we see folks, we're just seeing a snapshot too every usually, few months or whatever else too. We're seeing a snapshot of how you're feeling on that day. So having that journal and keeping track of your symptoms can be really helpful for us too. But typically if an MPN is progressing or not responding to a treatment like we want it to, we'll see typically other signs too. We'll see changes in the blood counts, changes in those other lab values like the LDH number. We might see changes in the differential, like those blast cells going up. We might see spleen size starting to increase. It's usually not just one thing. It's usually a number of different things all at once.
True. Are there any lifestyle changes MPN patients should adhere to hinder progression?
Oh, to hinder progression, that's a tricky one. I'm not sure that any lifestyle changes make a big impact in the overall biology of the disease or the natural course of the disease. But I think they can make a big difference in terms of your quality of life and your functionality and your symptoms, as well as potentially for your eligibility for treatments down the road too. So things like, stem cell transplants, for example, people have to be, quite fit to consider that kind of intensive treatment. So definitely lifestyle changes, diet, activity level, quitting smoking, alcohol use, limiting alcohol use, those kinds of things can be helpful when we're talking about treatment eligibility for more intensive therapies. But yeah, symptomatic wise and quality of life wise, absolutely too. I've seen it many, many times in the clinic that folks make dietary changes. Like I mentioned, the anti-inflammatory diet, which is nothing crazy or off the wall. It's like a Mediterranean diet, generally a heart healthy diet. I think it goes a long way towards helping people feel better. I'm, not saying it's easy. I'm not saying it has to be 100% perfect all of the time, but I think it really can help. And I think same thing with regular cardiovascular exercise or things like yoga. All of those things, all three of those things have been shown to decrease cytokine levels in the body, decrease inflammation in the body, and help people feel better with these disorders. So I think there's really no downside other than maybe missing out on, some of the other foods you like, but not saying you can't have any of them.
Has any research been done on the effect that the consumption of animal proteins has on the progression of MPNs? And they're referring to the results of the China study by Dr. Colin Campbell from Cornell.
I'm actually not familiar with that study, so I'm not sure about the answer to that. I can look into that, but I'm actually not sure. I'm not sure that animal proteins have been shown, but I'm just not aware of that study, so I'm not sure about the answer. I'm sorry.
Yeah, and there's obvious research out there about eating meat and so on that is not so great. and I can vouch for that. But anyway, moving on. Yeah, I'm not familiar with this study as well, but I'm going to look into it because that sounds very interesting. So this is kind of a sad question, but one that has to be asked, and that is, will all MPN patients eventually progress if they live long enough?
That's a really good question. I have strong feelings about this question.
Yeah.
My feelings are no. I think that progression with MPNs is not necessarily a natural or inevitable thing that's going to happen. When we do see progression of ET or PV to myelofibrosis, typically what we see along the same course is acquisition of additional genetic mutations. So you may have had a JAK2 mutation for several decades, and then a subset of those cells with a JAK2 mutation, a subclone, will develop an additional mutation in another gene, or several additional mutations that will cause it to kind of turn in a different direction towards myelofibrosis. And the risk of that happening does increase over time, certainly. We're not talking about weeks and months, we're talking about years and decades of that, the longer that mutation is there, the higher risk that can happen over time. But I absolutely do not think that that's an inevitability.
Okay, and I have one more question, and then I will do a wrap up with you if you just leave us with a little bit of hope. And then we'll do our industry partner updates, which are always very interesting. And the last question is a good one because, over the years, I hardly ever hear about anagrelide anymore. I know that a few patients are still taking that with another drug, for MPNs. But why has the frequency of use diminished?
Yeah, anagrelide has kind of fallen out of favor over time for a number of different reasons. I think the number one reason is side effects. There's more bothersome side effects in general. Certainly there are some people that tolerate it perfectly well, but cardiac issues like palpitations, heart failure worsening, swelling, those kinds of things are real and serious possible side effects. Headaches or dizziness can absolutely happen too. And I think it's, historically just not quite as good of a drug as some of the others that we have for controlling symptoms and potentially for preventing blood clots too. It is nice in that it's very specific for the platelets as opposed to the other blood cells. So there are still some situations where we use it. There was recently, within the last, year or 2 years, there was an anagrelide shortage as well. So I think many of our patients that did remain on anagrelide from way back when, we had trouble finding it for a period of time, and that was kind of a trigger to move many of those folks to other medications during that time too, that now have worked, and many people haven't gone back to anagrelide. So I think fortunately, that's kind of an evidence of the progression of research that has been done here, that we have better agents these days for most situations.
Yeah, I would agree wholeheartedly. And I wanted to add a little, or piggyback the answer to the other question about longevity with the diseases. And we know people that are in their 90s that have had PV since they were 40. And I mean, there are lots and lots of people living long and productive lives with an MPN, thank God.
Absolutely. Can I say one more thing about that too?
Sure.
Sorry, because I just thought of it too. Yeah, I think oftentimes by the time we diagnose somebody with an MPN, by the time they're kind of brought to attention and come to us, when we look back retrospectively in their medical chart, oftentimes we can see that they had elevated platelets going back to their 20s or, many decades before the disease was even diagnosed. So even though historically we've said that these are disorders of folks in their kind of 60s or 70s and on average, like you mentioned, we're seeing these younger and younger because I think we're doing kind of more medical care for people younger and younger and more attentive to picking these things up. But I think, many people by the time they're diagnosed have probably had this for many decades without something having happened. That's
right. That's very, very, very true. So Kristen, I know you have to get going and we want to get to our industry partners. What would you like to leave this audience with?
I think as a transition to the industry partners that there's a lot of, I think, hope for the future with these disorders. I think we have a lot of new treatments already that have come forward into the clinic just since I've been, in practice and training over the past decade or so. And there are a ton of things coming, as you'll hear from the industry partners. I think things to help with medications or treatments to help with symptoms, to help hopefully prevent progression, to hopefully actually help get down to the underlying cause of the disease and actually help get rid of some of these abnormal cells and make a bigger impact on the disease. So there are a ton of things going on. I would strongly encourage everybody out there who has access to an MPN center to be evaluated at some point, to discuss those options like investigational options, and just to make sure that your diagnosis and treatment plan is the best today, because what was the best 2 years ago is probably not the same as what the best is today. So making sure that you and or your physicians, your medical team are kind of up to date on and up to speed on where we are today, because it's changing so fast.
That's wonderful, and that's absolutely correct. And thank you so very, 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 very much. You've done a great job. And for the questions that have not been answered yet, we will send those along, or we'll be back next Friday with Dr. Gabriella Hobbs, who will be with us. And of course, Dr. Pettit is always not always available, but has been very available to us, and we so appreciate it. Kristen, thank you so very much. And we will move on now to our industry partners and get brief updates from some of those folks who help us to survive here at MPN Advocacy and Education International. Thank you, Kristen. So our first industry partner is Insight, and with us is Kristen Murray, who's an oncology clinical nurse educator. Kristen, are you with us? There you are.
I am, Kristen. How are you?
I'm good, thank you. Good to see you.
Good to see you. So I'm very pleased to be here today to represent Insight. And I would like to thank Anne and team at MPN Advocacy and Education International for giving me a few moments to speak about our company and its commitment to patients. I am grateful to have the opportunity to participate in today's meeting. We work and study these diseases on a daily basis, but value these moments. I get to hear your voices and questions, what is important to you, and how we as a company can help to be a part of a community of support. Insight Corporation is a Wilmington, Delaware-based biopharmaceutical company committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do to discover, develop, and deliver novel medicines that will meet the serious medical needs in oncology and other diseases. One of our most important commitments is to help ensure that appropriate patients may have access to the medicines they need. For this reason, we developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medication. Information for patient access can be found at www.insightcares.com. We are currently enrolling eligible patients in clinical trials for MPNs. If you are interested, please contact your healthcare provider. Detailed information about Insight's clinical trials can be found at www.insightclinicaltrials.com. We strive to enhance support in the patient community and to integrate the authentic patient voice throughout our initiatives. Partnerships like the one we have with MPN A&E International have been key in helping our understanding of the unmet patient and caregiver needs, including raising disease awareness and providing educational information to the community. We host a website called Voices of MPN. You can find that at voicesofmpn.com, where we provide access to MPN information, patient stories, access and information for MPN community events, patient meetings, podcasts, and symptom tracker tools. We created a program called MPN Heroes to publicly recognize individuals who have excelled in caring for a patient or patients with an MPN or have advanced the science in MPNs to increase awareness and support the MPN community. MPN Heroes will be a hybrid event this year. The live portion will take place at the National World War II Museum in New Orleans, Louisiana, this year on Friday, December the 9th at 7:30 p.m. Central Time. Cure is hosting this event. At Insight, we believe that industry and patient groups can find common ground to develop collaborative partnerships resulting in meaningful activities. Programs like this allow Insight to use our resources to help improve the lives of individuals most impacted by the diseases in which we work. And with that, I
Thank you
appreciate
very
you
much.
having me.
Yes, thank you very much, Kristen. I really appreciate you being here today, and that was very nicely put. Thank you.
Absolutely, it was an honor.
So we are moving on to Delian Blaine, who is the Assistant Scientific Director at AbbVie. Hello, how are you?
Good, thank you, Anne. Thanks to Anne and her colleague at MPN Advocacy and Educational International for allowing me to discuss AbbVie's clinical myelofibrosis program today. As Anne mentioned, my name is Delian Duan, and I am an Assistant Scientific Director in U.S. Medical Affairs at AbbVie. AbbVie is a global pharmaceutical company and a leader in the transformation of care for patients with blood cancers. We're striving to advance standards of care and bring transformative treatment options to patients, including those with myelofibrosis. We are currently evaluating navitoclax in myelofibrosis. Please note navitoclax is an investigational agent and not currently FDA approved. Safety and efficacy are still under evaluation. Navitoclax is a first-in-class oral small molecule that binds to two proteins called BCL-XL and BCL2, which are pro-survival proteins that prevent cells from dying. Cancer cells can hijack the machinery that makes these survival proteins to keep themselves alive. Navitoclax binds to BCL-XL, which can cause myelofibrosis cells to die. JAK inhibitors shut off the pathway that increases production of BCL-XL, making myelofibrosis cells susceptible to BCL-XL inhibition. Given the results seen in the phase 2 REFINE study, AbbVie has proceeded with 2 phase 3 studies in fall 2020, both evaluating the combination of navitoclax and ruxolitinib in myelofibrosis in a larger patient set. The first study, TRANSFORM-1, includes patients with myelofibrosis who have not received prior treatment with a JAK inhibitor and is evaluating the safety and efficacy of navitoclax combined with ruxolitinib versus placebo and ruxolitinib. The second phase 3 study, called TRANSFORM-2, is currently seeking more patients to participate. This study includes patients with myelofibrosis who have worsening disease, as evidenced by enlarged spleen and symptoms, despite previous or current treatment with JAK2 inhibitor. TRANSFORM-2 is an open-label study, meaning that patients and investigators will know what agents they are receiving and will evaluate a combination of navitoclax and ruxolitinib versus the best available therapy, which is at the discretion of the physician and could include ruxolitinib, fedratinib, among other options. We currently have more than 30 sites across the US for each study, and TRANSFORM-2 is still seeking patients to participate. You can find more information regarding the ongoing studies at www.myelofibrosisresearch.com. The site includes further information about each study, a questionnaire to determine if patients might be eligible to participate, and a map of current site locations. And thank you for your time.
Thank you very much. We really appreciated that. And so moving on, we'll go to Pharmacentia and Dr. Ray Urbanski. Ray?
Hello, Wayne and Mallory. How are you?
Good.
You'll have to forgive the barking in the background. Obviously, throughout the Dr. Pettit's talk today, we heard quite a bit about interferons and their utility in MPNs. I'll speak a little bit, give you a little bit of information about Besremi, which is Ropeg interferon, which Dr. Pettit mentioned several times. It was approved in November of this past year, for the adults with PV, regardless of their treatment history. So what that basically means is Besremi could be used in an adult patient with PV, whether it's in their first line setting or whether they've had other therapies beforehand, which is fairly significant because most oncology drugs are never approved across multiple lines of therapy, such as Besremi was. Now, Besremi is unique, as you mentioned, and it's different than Pegasus, it's different than Peg-Intron and all the earlier generations, because this is a site-specific monopegylated interferon alpha-2b, and that leads to a very homogeneous or very pure sort of isomer for the drug. So you don't have a whole host of different types of drug molecules within the formulation that the patients would be taking. So with that, one of the things that also would come up, and Dr. Pettit mentioned it, is around the potential for disease modification and not simply looking to control a specific count or a specific number or a specific groups of numbers. And this is important. Obviously, she mentioned the allelic burden, the VAF, variable allele frequency, et cetera. And our clinical data clearly shows that Besremi has had an impact on the number of JAK2 mutated cells in the PV setting. Now, with that being said, we are also doing studies in ET. We currently have our Surpass ET, which is a global study, and comparing it to anagrelide. Obviously, Dr. Pettit mentioned some of the challenges with anagrelide, especially in the US, with all of its side effects, et cetera. So we're looking forward to this reporting out sometime next year. Within the US, we're also conducting a single-arm study in ET to support and supplement the global study. And also of note, we have a single-arm study in polycythemia vera. Even though we're approved in that indication, we're actually looking at a modified dosing regimen that we think or we believe will actually lead to an increase or a more rapid control of the disease, as well as a large impact on the disease burden, meaning that those mutated stem cells actually go away much more quickly. And that's also getting conducted, as I said, in the US. Also of note, and I think this was also raised, is the pediatric, adolescent, and young adults. So these classically are the low-risk patients. Now, because of Besremi's disease potential for disease modification, we firmly believe that this watchful waiting or wait for the patient to have something bad happen, and then you start them on a drug, or wait until they happen to turn 60 years old. We think that that sort of paradigm is about to be changed. And we think because of Besremi's potential for disease modification, that all of these patients, the pediatrics, the adolescents, young adults, even though they're considered low risk, should be treated with some kind of disease modification. And so we're looking at that as well. So with that, I'll end. Thank you so much, Ann.
Thank you, Ray. I'm glad you pointed that out, because that was a big question, that gets asked here quite often. Thank you very much.
Thank you.
So moving right along, we are with Alicia Shilton-Lloyd, who is the VP of Medical Affairs at Imago Biosciences. Hello, Alicia.
Hi, Anne, and hi, everyone else. As Anne mentioned, I am the VP of Medical Affairs at Imago Biosciences, where I head up our patient engagement activities. And Imago is a biotech focused on how a key pathway of blood cancer development can be targeted to create transformative medicines. One of our lead agents is bomedemstat, which is a novel inhibitor of LSD1, which is lysine-specific demethylase 1, and quite a mouthful. Dr. Pettit actually showed this when she was discussing research in MPNs with that really cool schematic of where various potential treatment agents are acting in the cell. Bomedemstat is a new once-daily oral medication in late-stage clinical testing. Bomedemstat is an investigational agent, which means that it's not yet approved by the FDA for use outside of a clinical trial. The FDA has awarded Fast Track designation for bomedemstat development. Fast Track is a process designed to facilitate the development and expedite the review of drugs to treat serious conditions and fill an unmet need. And bomedemstat has been awarded this designation for essential thrombocythemia and myelofibrosis. Our studies in over 200 patients have shown us that bomedemstat has demonstrated activity and is well tolerated. And we presented this data in June at the European Hematology Association Conference, or EHA. in Vienna. You can find full data posters on our website, www.imagobio.com. And plain language versions of those posters can be accessed by visiting the patient resource section on our website. I'm really excited today to share that we will be starting our phase 3 trial evaluating how Bomedemstat can improve the lives of patients with essential thrombocythemia later this year, as well as a phase 2 trial in PV. And that phase 2 study is listed on clinicaltrials.gov and can quickly be found by searching for PV and Imago. Thank you, Anne, so much for inviting us here today. It was an excellent lecture. We're so grateful to hear from the patients, the fantastic questions, and from Dr. Pettit just regarding her guidance and her thoughts. And as always, Anne, thank you so much.
You are very, very welcome. And thank you for that information. That's great, great stuff. And just to let you know, we do have clinical trial information on our website, but very often linked to clinicaltrials.gov. Because it's so much more comprehensive. So thank you again, Alicia. So we will move on to GSK and Lori Wilcoxon. Are you with us? There you are. Hello, Lori.
I am. Thank you so much for having me today. So good morning, good afternoon to all of you. And thank you all so much for joining this great presentation today and allowing me the opportunity to speak with you as well. Again, my name is Lori Wilcoxon, and I'm a patient engagement liaison with GSK Oncology. So a little bit about GSK. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK's mission is to maximize patient survival through transformational medicines, and the focus is including immuno-oncology, cell therapy, tumor cell targeting therapy, and synthetic lethality. Our goal is to achieve a sustainable flow of new treatments based on a diversified portfolio of investigational medicines utilizing modalities such as small molecules, antibodies, antibody drug conjugates, and cell therapy, either alone or in combination. In July of this year of 2022, GSK completed the acquisition of Sierra Oncology, which is a California-based biopharmaceutical company focused on targeted therapies for treatment of rare forms of cancer. The acquisition of Sierra Oncology includes momelotinib, a late-stage potential new medication, which has a unique dual mechanism of action that addresses the critical unmet medical needs of myelofibrosis patients with anemia. So speaking to momelotinib, in August, GSK announced that the FDA had accepted the new drug application for momelotinib, and if approved, momelotinib will contribute to GSK's growing specialty medications, with the US launch anticipated in June of 2023, so not far off. The new drug application is based on the results from key phase 3 trials, including the pivotal MOMENTUM trial. The primary analysis data from the MOMENTUM trial were recently presented at the 2022 American Society of Clinical Oncology annual meeting and the European Hematology Association 2022 Hybrid Congress. So in closing, I would just like to say thank you again, and that we are so grateful at GSK to Anne Brazeau and the entire myelofibrosis advocacy community for all the work you're doing to raise awareness and educate patients and their care partners about the disease. We appreciate the partnership that we have with you and the MPN Advocacy and Educational International. And thank you again for this opportunity to tell you and your listeners about what we are doing at GSK Oncology. So again, thank you so very, very much.
Thank you, Lori. That was great. And I mean, I sit here after almost 20 years in this space, and it's astounding what's happening. It's such a great time. Very happy to hear from you. Thank you.
You are welcome.
On to Deb Hoyer at CTI Biopharma. Are you with us, Deb?
Yes, Anne, can you hear me?
Yes.
Thank you so much. As Anne shared, my name is Deb Hoyer, and I am a senior medical science liaison at CTI Biopharma. Can't thank you enough for hosting this educational event, Anne and the entire MPN advocacy and educational team. In addition, giving us the opportunity to provide an update about our work at CTI. We recognize that it's patients, clinicians, and industry working together to improve therapies and patients' lives, especially in areas of unmet medical needs like in myelofibrosis. Patients who have myelofibrosis and cytopenias have had limited treatment options until earlier this year when pacritinib, a JAK1 sparing, JAK2 IRAK1 inhibitor, received accelerated approval by the Food and Drug Administration. Pacritinib is marketed as Vonjo. It's an oral agent, and it is approved for adult patients with myelofibrosis with very low platelet counts, meaning less than 50,000, because we recognize that these patients often have more advanced disease, and many cannot tolerate currently available therapies at full dose. The approval of pacritinib was based on efficacy results from the pivotal phase 3 PERSIST-2 study in patients with low platelet counts less than 100,000, which compared pacritinib at 2 doses to best available therapy that included ruxolitinib. As part of our accelerated approval, CTI is required to describe a clinical benefit in a confirmatory phase 3 trial called Pacifica that is enrolling in the rest of the world but excluded in the United States. In March, the National Comprehensive Cancer Network guidelines included pacritinib not only for patients with myelofibrosis who have platelet counts less than 50,000, but also as a second-line therapy after prior JAK2 inhibitors used when bone marrow transplant is not an option. Pacritinib is also an option for low-risk myelofibrosis patients who have lost or not achieved symptom burden response. Our pursuit of advancing novel treatments for blood cancers begins with pacritinib. At CTI, work is being done to explore pacritinib's unique mechanism of action and potential use in other disease states through our clinical research program. CTI is committed to ensuring that eligible patients can access pacritinib through a comprehensive patient support program called CTI Access. Our team is enthusiastic for our partnership with MPN Advocacy and Education International and we continue to support rigorous science and data that will bring much needed treatment options to patients living with myelofibrosis, with the goals of improving symptoms, spleen response, and providing hematological stability and/or improvement. I would like to thank you, Anne, the MPN Education International Group, patients, families, caregivers, and my pharmaceutical colleagues.
Thank you very much. I appreciate that, Deb. And we will move on to Joy Lawyers from Protagonist.
Hi, Ann. Hi, May.
Hi, Joe.
Good to see you again.
Good to see you again.
Thank you for having me. My name is Joe Loris. I'm one of the directors of medical affairs here at Protagonist. And again, I want to thank you for allowing me to talk about our company and our research in polycythemia vera. Protagonist Therapeutics is a biopharmaceutical company located in South San Francisco Bay Area. We have about 150 employees. Our platform is based on a proprietary peptide technology. Our lead drug candidate is called rusfertide. It's a synthetic mimetic of the natural occurring hormone hepcidin. Hepcidin regulates iron homeostasis and controls the absorption, storage, and distribution of iron in the body. Based on the data from our 70-patient phase 2 study, the FDA has allowed us to move forward with our phase 3 trial for patients with polycythemia vera. This is a global trial with 100 sites, and we are now recruiting 250 patients. The phase 3 study allows both high-risk and low-risk patients, PV patients, to enroll in the study. The phase 3 global randomized placebo-controlled trials evaluating the efficacy and safety of a once-weekly subcutaneously self-administered dose of rusfertide in polycythemia vera. We have a patient website that actually will help the patients look and ask a few questions to see if they qualify for the study. The website is www.polycythemiavera-clinicaltrials.com. That's www.polycythemiavera-clinicaltrials.com. And with that, thank you, Anne, for, again, having us and what you do for patients. It's been wonderful to hear Dr. Pettit today and get to hear all the patients.
Yeah, thank you, Joe. It's good to see you again and hope you're well. And thanks for your update. And we will move on to our last industry partner here today, and that is from Morphosis. And Matt, Abramian. I hope I said that correctly, Matt. It's my first time meeting you.
I'm just trying to get off
There you
camera
are.
mute. There I am. Yes. Hi. You did say it. Matt Abramian. So thank you for that introduction. So yes, I'm Matt Abramian. I'm a senior medical science liaison at Constellation Morphosis Medical Affairs. Constellation is a Massachusetts-based biotech company with over 12 years of discovery and development history focused on epigenetics and cancer biology. Constellation's drug candidates, which were all internally discovered, are the product of our expertise in gene targeting for diseases where gene regulation and control matters. As of July 15th, 2021, Constellation Pharmaceuticals is now a Morphosis company, and we are committed to delivering breakthrough therapies that bring hope to patients. The lead compound generated at Constellation is an investigational BET or BET inhibitor, pelabresib, also goes by the name of CPI-0610, that we are developing as a potential treatment of myelofibrosis to selectively, so pelabresib is a novel orally administered small molecule designed to selectively inhibit the function of BET proteins to decrease the expression of abnormally expressed genes in cancer. Please note that pelabresib is an investigational new drug and is not yet approved by any regulatory authority. So Constellation is currently conducting a phase 2 clinical trial of pelabresib in myelofibrosis and essential thrombocythemia, and a larger phase 3 trial, Manifest-2, has initiated for myelofibrosis. Manifest-2 is a randomized double-blind phase 3 trial in adult patients with myelofibrosis who have not been previously treated with a JAK inhibitor. The purpose of the study is to evaluate the efficacy and safety of pelabresib plus ruxolitinib, a JAK inhibitor, compared with ruxolitinib alone. For more information, you can find both Manifest and Manifest-2 trials at clinicaltrials.gov or check out our website at manifestclinicaltrials.com. Our interest. Oh,
I'm sorry. I thought you were done. Thank you.
Sorry. No, a little bit more. Our interest and commitment to patients and caregivers extends across the MPN community, as we have additional plans for pelabresib in early stage programs that may have utility in multiple in MF and other MPNs in the future. And a final thank you to you, Ann, and MPN Advocacy and Education International, as well as our distinguished panel for the opportunity today. Now I'm done. Back to you.
Thank you very much. That was very informative as well. I really encourage the patients to listen to all of the biopharma updates and our industry partners, because this is kind of a roadmap to their future as well. And thanks again to Dr. Pettit and to all of you and to all of the patients here today and that were with us and are with us. And your questions will, again, next week, we have Dr. Gabriella Hobbs with us next Friday, and you should be receiving more information about that this week or next week. Thank you very much and have a great day.
You too.
Thank you, Ann.